Good night, everyone, and I hope that you are having a good evening so far. And I'm glad to be here once again. As you know, we have another special guest. You can see her right here. Dr. Foteini Chouliara is with us.
Hello.
Hello, Dr. Foteini. How are you feeling tonight? Welcome to my IVF webinar.
Thank you. Thank you so much. Thank you for your kind invitation.
Thank you so much for saying yes and, of course, presenting our topic tonight. So we will talk about low ovarian reserve. And as you know, now we are focusing on success stories, and Dr. Foteini will talk about this, and she will definitely present some interesting cases for you. And she will also talk about low ovarian reserve. So as always, I'm sure it's going to be interesting for you, but as always, remember to type the questions in the chat section, as Dr. Foteini will definitely help you out with them. And I'm your host, Caroline, and I just want to add that probably some of you already know, but let me just remind everyone that My IVF is a part of European Fertility Society. And as you know, since September, middle of September, we started the project about success stories. We've done many webinars, of course, on different topics, but we are focusing on success stories because we just want to share with you the options that you might have, but also you can see that even in the worst case scenarios, there is some light, there is some hope, and of course there are some amazing success stories there. So I'm glad that you are right here with us. I do believe it's going to be useful for you. So I guess that is it from me. I believe we can start. Are you ready, Dr. Foteini, to begin with your presentation? You can start
Yes, of
sharing, of course,
course.
your
Thank you.
presentation. Thank you so
Thank
much.
you. So I'll start sharing.
Wonderful.
Okay. Hopefully I'll do this right.
Now I'm sure it's going to work perfectly. I can see it already, so it's all good.
Excellent. So we're on the right track.
Exactly. You can,
Okay.
yeah. Now we can see it perfectly. Thanks so much.
Excellent, excellent. So thank you so much, Caroline, for your kind invitation. It is my pleasure to participate in this very, very interesting series of webinars. And without further ado, I'm going to start with the presentation of the case studies that I have selected for you. So the first case study is about this lovely couple who attended our clinic about a year ago. The female patient was 37 years old with a good BMI. She mentioned a hysteroscopic polypectomy and laparoscopic myomectomy in the past. She also mentioned family history of early menopause. She's not a smoker and not a drinker. Her husband, 47 years old, again without any serious health problems, not on any regular medication, and again good habits of no smoking and no drinking. Now, this couple was faced with infertility for about 11 months. They did mention a previous IVF cycle in the past. And after our diagnostic workup, which involved meticulous history taking, ultrasound evaluation, blood work, AMH levels, sperm analysis, karyotypes, and so on, everything came back normal except for an AMH of 0.4, which is actually pretty low for a woman who's 37 years old. Now, as I mentioned before, the couple already had one IVF attempt about 7 years earlier. In that attempt, our colleagues had tried classical antagonist protocol. They managed to retrieve A2 sites and in the end produced two blastocysts, which were transferred and unfortunately without obtaining a pregnancy. So before starting our own attempts, we went ahead with vitamin D supplementation and, of course, multivitamins in order to help with the low ovarian reserve. We also chose to start with a classical antagonist protocol, which is a very patient-friendly protocol, and chose a combination of Gonal and Menopure with a total of 300 units administered per day. In this stimulation cycle, however, we didn't manage to get as many oocytes as the couple had in the very first attempt. Again, reminding 7 years ago, we had 2 follicles growing, but we were very, very lucky, and both of the follicles had mature oocytes. And out of the 2 mature oocytes, we managed to produce 2 pretty good blastocysts. We performed fresh embryo transfer of both embryos, as we can see them here. And we did have a positive pregnancy test. On our initial ultrasound examination, we had 2 sacs, 2 heartbeats. Unfortunately, one of our twins regressed at around the 13th week of pregnancy, but the remaining twin managed to thrive and actually was delivered by a C-section at 39 weeks. And we had a healthy full-term baby boy. So I think the main key point of this case study is, first of all, that the most important factor for a woman's fertility is that of age. Okay, unfortunately, we might age nicely, but our oocytes have got a declining quality as we're growing older. Now, the same actually happens with ovarian reserve. So just to give you some background information, when we are born with a set number of oocytes that are available to us throughout our reproductive life. And this number of oocytes starts to decline even while we're in utero. So we might start with 6 to 7 millions of eggs. By the time we are born, we have 1 or 2 millions of these eggs, and by the time we hit puberty, around 3 to 400,000 are available to us. Now, as the time goes by, and with every cycle, many of these eggs are recruited, and as this initial ovarian reserve, this initial pool of eggs is being consumed, when it is worn out, we enter menopause. So we can see that as time goes by, so does our ovarian reserve, and this is absolutely normal. Now, unfortunately, there is a very small proportion of women that might have a lower ovarian reserve than expected for women their age. This could be because of genetics, because of other factors, of other conditions such as endometriosis, because of smoking, because of having previous surgery on their ovaries, or because of therapies such as chemo or radiotherapy. Now, an excellent marker to assess this available ovarian reserve is that of AMH, anti-mullerian hormone. And this is a marker we usually use in IVF in order to determine the ovarian reserve and to actually predict the ovarian response. I'm not going to tire you with a lot of information, just to mention that AMH is produced by the little follicles that we see on the ultrasound. And we can see that the value of AMH is also declining with age. Okay, so it's really, really important to check the AMH early on and to seek specialist advice. If we are with a partner and our AMH levels are very low, then we can either start trying to conceive right away, and if we're unsuccessful, or if there are other factors in infertility, seek specialist advice right away. Or if we are single, we're still pursuing a career, or we haven't met Mr. Right guy, then maybe social egg freezing could be a very good option for us in order to maintain our fertility for later on. So let's move on to the second case study. Now, this is another lovely couple that visited our clinic about a year and a half ago. The woman was 39 years old, very good BMI, mentioned hypothyroidism, which was treated regularly with thyroxine and was well regulated. She also mentioned repeated E. coli infections. She had had a diagnostic hysteroscopy in the past. And biopsies were taken showing chronic endometritis. She was on multivitamins and again, not a smoker, not a drinker. Her husband, 39 years old as well, he maintained a good body weight with no serious health problems, and he had good habits of no smoking and no drinking. Now, this couple was trying to have a baby for about 4 years. And after our initial workup, we had an AMH of 0.7. Karyotypes were normal, thrombophilia screen was negative. We did perform PCR of sexually transmitted diseases because of this history of constantly having vaginal infections, which again came back negative, and the hysterosalpingography and the sperm analysis were actually very good. So again, the main infertility factor here was the low AMH. The couple did have one previous IVF attempt about a year prior to visiting our clinic. The classical antagonist protocol was used at the time. They had managed to retrieve 16 oocytes, producing day 5 embryos, which were gradually transferred in 3 separate endometrial preparation cycles, unfortunately without achieving any pregnancy. Now, in our case, we decided to go ahead with a different protocol, trying to see if the long agonist protocol could actually yield us better results. So we started our RVCAP injections on the luteal phase of the cycle prior to the stimulation cycle, and then again used a combination of gonal and menopure injections. At the end of the stimulation, we managed to retrieve 16 oocytes, which was very, very good. And at the end, culture 5 very good quality blastocysts. Now, in this particular couple, we decided to perform pre-implantation genetic screening, and out of the 5 blastocysts, 2 of them were found to be euploid. Before transferring the blastocysts, we wanted to evaluate the endometrial cavity, and that's why we performed a hysteroscopy. The endometrial cavity was found normal, but we did go ahead with endometrial fundal scratching, which is something that we regularly do at our clinic. We decided to transfer, after discussing with the couple, both of the blastocysts, and things turned out pretty good as we delivered a healthy baby girl at 37 weeks along. Now, I think the main key points from this case study is the importance of actually changing the therapeutic approach. I mean, not all couples are the same, and not all couples respond well to the same protocols. There isn't one size that fits all. So it's very, very important to actually try to have an individualized approach to every couple. So in this case, we had seen that the classical antagonist protocol didn't work that well for the couple. And although it's much more patient-friendly, we decided to change and actually try the long agonist protocol, which in this case proved us right, since it gave us the desirable result. In this couple, again, we also chose to do PGTA, pre-implantation genetic screening for aneuploidies, which is a method that it's not regularly done for every single couple. It's not for everybody, as it is an invasive procedure. It is a biopsy done on the embryos, and we usually perform it for women who are over 40. They have been plagued with repeated implantation failures, recurrent pregnancy failures, and with couples with severe male factor. Now, PGT is not a treatment. It's a diagnostic tool, and at the same time, it helps us to decrease the time until we achieve pregnancy. It really saves us from all the heartache and pain of transferring embryos that have no chance of implanting and giving a live birth. And moving on to our third case study, this is about a couple that visited us and sought advice about 2 years ago. The female patient was 40 years old, good BMI, with Hashimoto thyroiditis, under T4 thyroxine supplementation, again, not a smoker, not a drinker. And her husband, again, nothing significant from his own personal or family history. Now, this couple have been trying for a baby for about 6 months. They had no previous IVF attempts. The female patient's AMH was 0.2, again, pretty low for her age. She had an intramural fibroid that was flirting with the endometrial cavity, and we were suspecting 1 or 2 polyps from her ultrasonography. There was also tubal factor. One of the tubes seemed to be off on the hysterosalpingography, but the sperm analysis was overall good. Now, in this case, we started off with some vitamin supplementations, and we chose to start with a classical antagonist protocol using Gonal. This actually didn't go very well for us. We only managed to have 1 follicle, and there was no oocyte found after oocyte pickup. So after that, we discussed it with the couple, and since the couple didn't really want to waste any time and wait for about 3 to 4 months in order to have another full dose stimulation cycle, we decided to go with a package of natural cycles, or naturally managed natural cycles. In the first packet of, we call it packet of the natural cycles, in the MNC cycle, we managed to get 2 very good quality blastocysts that we vitrified. And then we moved on to another 3 cycles where we accumulated 1 more blastocyst, and in our third package we accumulated 1 more, so at the end we had 4 lovely embryos waiting for us to transfer. Before doing so, of course, remember we had some uterine factors, so we started off with the laparoscopic myomectomy. Afterwards, we went ahead with ERA testing after, it was a wish of our female patient to do the ERA testing before doing any embryo transfers. And of course, we did a hysteroscopic evaluation of the uterine cavity and endometrial fundal scratching. Since everything was set and everything was checked, we went ahead and transferred 2 of our blastocysts. We did get a positive pregnancy test the first time round, but unfortunately, our patient lost the pregnancy at around 8 weeks along. We weren't discouraged. We still had our 2 last blastocysts, which we did transfer on a natural cycle. And yes, things went really, really well. At the moment, our patient is at 30 weeks and expecting a baby girl. I think the main key point from this case scenario is not to be discouraged easily. A woman who have got a low AMH doesn't mean that they are infertile. It just means that they respond more poorly to ovarian stimulation, and this means that they might need more cycles in order to accumulate more oocytes and have a better chance of having good embryos within this group of accumulated oocytes. So moving on to our fourth case study. Now this couple, they sought advice about 2 years ago. The female patient was 41 years old at the time, good BMI. She had 3 hysteroscopic polypectomies in the past. She was already on preconception vitamins and fish oil. Again, not smoking, no drinking. And her partner didn't have any significant health problems either. The couple were trying for about 2 years to conceive. Her AMH was 0.9. On ultrasonography, a septum was found, and again, an intramural fibroid, and the sperm analysis revealed mild male factor. Now, this couple had already had 3 previous attempts before visiting our clinic in the past 3 years. In the first attempt, they had a classical antagonist protocol with oral contraceptive pill priming. 9 oocytes were retrieved, 4 blastocysts were produced, leading to 3 FRET cycles with one biochemical pregnancy. Then on the second cycle, they had the classical antagonist protocol again, but unfortunately, none of the day 3 embryos that were transferred led to any pregnancies. And their third attempt, again with oral contraceptive pill and then with stimulation with gonal, didn't lead to any pregnancy either. So we decided to start off with a hysteroscopic evaluation of the uterus, and we resected the septum and we excised the polyp. And then we decided to go ahead with the long agonist protocol, since the classical antagonist protocol wasn't really helpful for this couple. Unfortunately, we didn't have any luck either. The cycle was cancelled because of low response. So we said, okay, let's try the classical antagonist protocol again, since it seemed to work better for this couple. We did do better. We retrieved 4 oocytes. 2 blastocysts, quite good blastocysts, were cultured. We did a fresh embryo transfer, but unfortunately we had a biochemical pregnancy. So the couple came back again and we tried another time the classical antagonist protocol. This time we had 2 oocytes, 1 day 3 embryo, which we let to reach day 5, but unfortunately it arrested. And then, since we really couldn't help this couple with these stimulation cycles, we opted for the natural cycle package, and we actually tried everything. We tried natural cycle. It didn't, we weren't successful. We tried minimal stimulation cycle. We managed to get 3 follicles, but they were all abnormal. We tried with aromatase inhibitors, and again, we didn't manage to produce a day 5 embryo. So after all these attempts, we had a conversation with the couple, and the couple actually took the decision of taking it a step further and choosing to go ahead with oocyte donation. So a very carefully selected and matched donor went through the stimulation cycle. 10 mature oocytes were retrieved, and we ended having 6 very good quality blastocysts, which were vitrified. They were vitrified in order to give us time to have a second look hysteroscopy and endometrial fundal scratching before actually proceeding with the embryo transfer. In this case, we did do an intralipid infusion before embryo transfer in order to enhance our chances with implantation. So once everything was ready, we transferred the first 2 blastocysts, and 9 days later we had a positive pregnancy test, and 40 weeks later the couple had a healthy baby girl delivered. So I guess the main key point from this scenario is that it's always a good idea to have a backup plan. Okay, unfortunately, low ovarian reserve is very, very challenging, and sometimes, despite our best efforts, things don't go our way. So, oocyte donation can be the answer for these couples who struggle to make it with their own eggs. Basically, the whole process involves, as I said before, a donor going through the process of the stimulation cycle, the oocytes that are retrieved that are then fertilized with the husband's sperm, and they are either transferred fresh or they're frozen and transferred later on as a part of an endometrial preparation cycle. Now, egg donation is voluntary and anonymous in Greece. Okay, for the egg donors to enter the donation program, they have to go through a whole evaluation process that involves a meticulous medical history, clinical examination, gynecological examination, a series of lab tests, and psychological evaluation. And once all these tests came back good, then they are accepted into the donation program. The matching process is done based on phenotypic characteristics and also, but not necessarily, on the blood groups of the couple and the donor. And oocyte donation is a very, very good plan B, since it's got very high success rates for all ages. The success rates reach about 50%, and they can get even higher while we're repeating oocyte cycles. So even if we don't get pregnant with our first embryo transfer, by having a second or even a third, most of the couples will have managed to achieve a pregnancy. And that's it for me. I hope you enjoyed the presentation.
Thank you so much. And definitely that was useful and interesting. Thank you so much for explaining all those cases. There were 4 cases, of course, and you always love to hear more success stories. And of course, that was an excellent, those were excellent examples for sure. And well, now it is your favorite part. We will go ahead with the Q&A time. As you can see, there are some questions ready. So again, let me just remind everyone that if you wish to ask Dr. Foteini anything, it's your time. Go ahead, type those in. And the first question that we've got is right here. When you found diminished ovarian reserve and, sorry, not sure here, fertility, perhaps for surgery, fertility indication, do you advise on-site freezing first and then go on with the surgery?
I'm sorry, I don't quite get it says, when you found diminished ovarian reserve and
surgery, because it's like surgery, I think. Yeah, it's about the surgery fertility indication. Possibly.
Oh, okay. So I presume that we have maybe a cyst or an ovarian mass, and prior to surgery, the physician thankfully checked the AMH levels and found out that they were quite low. I assume that's the question. And what do we do then?
Of course. I think so, of course.
Yes. So in these cases, I mean, it really depends. If the mass, well, let's start from the beginning. I think every surgery that is done on the ovaries, regardless of how careful the surgeon is always going to end up damaging ovarian tissue, and there is always going to be a follicle loss. So in that case, I would definitely advise to do some social freezing first, and then perform the gynecological surgery. Yeah.
Okay. Of course, if you have anything else to add, okay, just let us know, of course. But I do believe that it was the question you wanted to ask. And thank you so much indeed. And now let's have a look, okay? Now we will have a bit of a longer question with some details. I am 42 with low ovarian reserve. All of the tests are clear. I did 2 IVF sessions. First one was estrogen flare. 2 eggs were retrieved but didn't fertilize. Second IVF retrieved 4 eggs, 2 fertilized, didn't implant. My BMI is 23, non-smoker, in great health, and all tests were clear. Husband sperm analysis was normal. And my question is it worth trying one more time?
Oh, I know. This is so difficult. Yes, we've had this conversation with many couples, and I think it really depends. I mean, you've had 2 attempts so far. I think that if you have the stamina, the emotional stamina, and of course the financial backup to maybe try one more time, I wouldn't be against it. But I think as the stimulation cycles go on, they show us what the right decision is. I think maybe you can try one more time, but if that fails, I think that it wouldn't be bad to consider oocyte donation.
Understood. Of course. Thank you so much for your question and for your details that you have provided. I hope that it was also useful for you, but we always keep fingers crossed, of course, right? Yeah. Thank you so much. Okay, and let's have a look at the next question. And in the meantime, we did receive thank you from our patient right here. Okay, let's see. Why is PGTA proposed for a severe male factor if ICSI is performed and the best sperm is chosen?
Yes, of course. I mean, ICSI is very good when we have male factor. But it doesn't, I mean, the spermatozoa are chosen or on their motility, on their morphology, but then again, it doesn't make sure that the genetic material is perfect. So it might look good, but on the inside, it's like judging a book by its cover. So PGTA helps us with determining that the end result, which is the embryo, is normal. Because although the best spermatozoa are chosen, it doesn't necessarily mean that the end product, that the embryo, is also going to be normal. Most of the times, a bad embryo is because of a bad oocyte quality. Let's say 90% is because of bad oocyte quality. A smaller percentage is because of sperm, and it's usually because of a sperm that has got very bad parameters on sperm analysis. So in those cases that the couple have tried and they've had embryo transfers and they've been successful, it's worthwhile doing PGTA. And if the results are not very good, maybe they could consider sperm donation.
Understood. Again, thank you so much for yet another question. Definitely interesting, and of course for your help with this. Let's have a look. More questions are coming in. So, have you worked with anyone with AMH as low as 0.4 picomoles and was able to retrieve any eggs?
I'm really sorry about this. It's a very low AMH. I'm really sorry for that. But I guess it is important to know the age as well. The age factor is very, very important because it's a lot different to have such a low 32. Okay, thank you so much. So, I mean, 32 is not that bad because we might not have the quantity on our side, but at least we're hoping for better quality. So, I mean, maybe the stimulation cycle is not going to work very well for you, but you can always try with natural cycles. I mean, do you have regular periods? I don't know if, despite having such a low AMH, I don't know if this patient, if this lady is still having regular periods.
Let's wait. Okay, someone is typing.
Ah,
Yes.
okay.
Yes. Sorry. Okay. 28, 31 days. Yeah, so in between.
Okay. So I mean, for as long as she's having her periods, she has a chance every month to monitor her to monitor the cycle and to try to retrieve that oocyte, and maybe she will get lucky. So I wouldn't give up. I would try with every cycle for as long as I would have my periods. I mean, things would have been different if this lady was 42 or 43. Maybe it wouldn't be so much worthwhile. But at 32, I would definitely try. I wouldn't give up.
All right. Thank you so much. Okay. And let's have a look. Okay. There's another question from Sebastian. Why did you do intralipid infusion in case 4?
Yes, I mean, we've tried everything with this couple. We tried to try out anything that we could do to help them out. And the intralipid infusion was in an attempt to, I mean, the intralipid is like an emulsion, a fat emulsion solution, which might actually help with the implantation by regulating these sort of natural killer cells in the uterus, in the uterine lining. So it's not proven to be 100% effective, but there were some studies that suggest that by modulating this immune response in the uterus environment, it could actually favor implantation. So we did try it out.
Thank you for explaining, and of course, thank you for being also thorough, Sebastian. That means that you pay attention, so that's great. Thank you so much. And let's have a look. Of course, there's a great thank you from our previous patient, and let me just have a sec. Sorry, it's right here. Yeah. Okay. What is your opinion on PRP, ovarian rejuvenation method?
Oh. Okay, I can understand the way of thinking behind it. I mean, PRP, this plasma-rich, platelet-rich plasma, is being used in different specialties as well, in orthopedics, in dermatology, in a way of rejuvenating various tissues. I'm not very convinced that it can actually work. I think still we need a bit more evidence before actually applying it for most of our patients. Yes, I'm not quite sure if it's going to work. I don't think it's going to increase. I mean, that's the theory, that it might sort of rejuvenate and increase the follicles that are available. But I will wait and see more data and more evidence on how effective it actually is before applying it to my patients.
Of course. And do you do any trials, if I may ask, at the clinic?
We're not using ovarian PRP, but we're actually doing endometrial PRP for thin endometrium, for resistant thin endometrium. I mean, there is no harm done by the procedure, but I am not yet convinced, at least for the ovaries. I think in the endometrium, we have very encouraging results so far.
Okay, good to hear.
So
So
still
that's,
work in progress.
yeah, of course, I guess there are so many still things that we need to wait for some more data to be sure, yeah, that we can, of course, give it, I mean, propose that to patients, all patients. Thank you so much indeed for that question as well. And let's have a look. Is AMH fluctuating during the cycle?
That's a very good question, because so far we're talking about hormonal profile, and we always tell our patients to do their hormone levels between the second and the fourth day of the cycle. But the AMH is fluctuating throughout the cycle, but not so much. So it is okay. You can check it whenever. It's not that crucial. It's not that crucial. I think the most important thing is to perform it at a very reliable lab, uh, so that we get credible results.
Okay, thank you so much indeed then. And there are two questions very similar. So I just will show you. Why do you do endometrial scratch every time before embryo transfer? Why is uterine scratching used?
Yes, I see. We're very fond of endometrial fundal scratching in our clinic. Um, To be honest, it would be a very, very good idea to do a hysteroscopic evaluation every time before doing any embryo transfer. Unfortunately, this is not always easy, and it's a bit expensive as well. So we only go ahead with the hysteroscopy if there is valid evidence from our ultrasonographic evaluation that there is an abnormality, like a fibroid or a polyp or a septum. Now, even if no pathology is actually found, the hysteroscopy doesn't go to waste, because we do perform this procedure, which is called endometrial fundal scratching. It is like a scar that is done in the fundus of the uterus using the endoscopic micro scissors. And in a way, this injury to the endometrium seems to be activating regeneration factors, and it's another way of sort of rejuvenating the endometrium. We started doing this procedure, and we were very amazed with the results. And so it's something that we regularly do, and we're actually carrying out a study in order to be able to prove what we can see in our experience, but in order to have the statistics to back us up as well.
Thank you indeed for the questions. And of course, thanks for explaining. And now we might look at our final question. So if you have more, you know what to do. Go ahead, type those in. And the question is from Kat in regards to AMH as well. So when would you advise women to check their AMH?
Yes, I think that's so important. It's so crucial. I would definitely say to check it at least in their 30s, when they get 28, 30 years old, to check their AMH levels. So if they are in that very small proportion of women who are faced with low ovarian reserve and premature ovarian failure, at least they will have their options open before it's too late. And then there isn't much that IVF can do for them.
Of course, thank you so
So
much. And I think, yeah, this is still something that needs to be more talked about. Not everyone is. I think that most of the time people are checking AMH when it's time to, when something is not working.
Yeah.
So that's usually a little bit
Yes.
late, right? So thank you so much, Kat, for bringing this question indeed. Okay, sorry, just give me a second. Someone is typing. I just want to make sure whether we have another question or we will be finishing. So let's give it a minute. And thank you everyone already for joining us, for your questions. And as I mentioned, this is the final call. If you have more questions, go ahead, type those in. If not, remember that there is also an option for you to simply get in touch with Dr. Foteini and her team at Assisting Nature, located in Thessaloniki, and I'm sure they will be able and happy to help you out with more questions, with more details, because obviously any doctor needs more details to be able to properly answer, of course, right? So I think we will be finishing. Thanks a lot, everyone, for being here. Dr. Foteini, thank you so much. This is your first webinar with us, and I'm glad that we were able to do it with you. So thanks a lot for joining us tonight. And before we finish, is there anything else you would like to add?
Oh, I would like to thank you as well. It's been a lovely experience. It's very nice talking to couples, and hopefully, I really hope that they found this presentation helpful. And, you know, the advice I would like to give is just keep trying. Never give up. Never give up.
What else can I say after that, right? So, of course, as you always know, we are here and we are keeping our fingers crossed. And of course, as you know, also, we will be back on Monday. There is another webinar. We will talk about advanced maternal age this time. But don't worry, there are some more webinars left. So you will be able to ask your questions live as well. And thank you so much, Dr. Foteini. It's been a pleasure to have you here. I'm already looking forward for some more webinars with you. Fingers crossed as well. And now enjoy your evening. I know it's been a busy day for you, and so I hope that you will have a relaxing evening. And to everyone, thank you for joining. Thank you for your questions, because I know some of you come here sometimes even every day. So thanks a lot for that indeed. As you know, it has been recorded. You will be able to find it on myivfanswers.com. So that's it for today. Thank you so much. Take care.
Okay, thank you. Good night. Bye-bye.